Good afternoon, everyone. Welcome to today's update on COVID-19 in Alberta. With us, as always, is Dr. Dina Hinshaw, Chief Medical Officer of Health for the province. Dr. Hinshaw will provide a brief update, and then we will open the floor to questions.
Thank you, Tom, and good afternoon, everyone. Before I provide today's numbers, I would like to provide an update on our contact tracing system. Throughout the fall and early winter, AHS has been working hard to expand our contact tracing capacity. We are now able to reach out within 24 hours to all high-priority cases of COVID-19, including those involving school-aged children, healthcare workers, long-term care workers, and those who are involved in critical response. We continue to prioritize contact tracing for other cases involving minors or those working or living in continuing care or other congregate facilities. With more contact tracers and fewer cases, we are reducing the number of cases with unknown exposures. Currently, only about 47% of our active cases have an unknown source. This is down from about 80% on December 10th to 15th. It is important to note that investigations into recent cases are still underway and that identifying a source of exposure is complex. Even with a fully functioning system, there are always a portion of cases, usually around 30%, where the source of exposure cannot be identified. We are making progress, and we will continue to build our capacity. Turning to today's numbers, over the last 24 hours, we have identified 652 new cases of COVID-19 in the province and completed about 9,300 tests. That puts our current positivity rate at about 6.8%. Schools have resumed in-person classes. Right now, there is currently one school on alert with a single case. There are currently 819 people in hospital, including 132 who have been admitted to the ICU. Sadly, 38 new deaths were reported to Alberta Health in the last 24 hours. We must always remember that these figures are not just numbers, but lives. Every death involved somebody who was loved and was loved by many. My thoughts go to everyone who is mourning a loss of a loved one from any cause. Yesterday, we expanded immunization to include paramedics and emergency medical technicians. This comes after AHS started offering immunizations to healthcare workers in all COVID-19 units, medical and surgical units, and operating rooms last week. I want to thank all healthcare workers for their work and for signing up as soon as possible to receive the COVID-19 vaccine. You have done remarkable work for many months, serving on the front lines, often putting your own health and well-being at risk. Being immunized will help protect patients and slow the spread of COVID-19. And importantly, it will help protect you, and you are a vital part of the team. I also want to thank Albertans for being patient as we are rolling out the vaccine. We are rolling out vaccine as quickly as possible and every day seeing more and more Albertans immunized. As we get a clearer picture on the number of vaccines available, we will be able to make decisions on Phase 2 in the coming weeks. I know that a great many groups would benefit from this vaccine, and we will continue expanding our approach as more vaccines arrive. In the meantime, we must all continue to make safe choices and follow public health measures to reduce the spread of COVID-19. Thank you, and I'm happy to answer your questions.
All right, we'll go to the phone now. Operator, could you put through the first caller, please?
Our first question comes from Kevin Nimick from CTV. Your line is open.
Hi, Dr. Hinshaw. Two questions for you today. In terms of COVID-19 deaths, do you believe 2021 will be even more deadly than 2020? And also, seeing today some businesses choosing to open against provincial rules, what sorts of punishments would you like to see for these businesses? Today we saw that they were forced to close, but they weren't given tickets. Do you think that all businesses that open against the provincial rules should be forced to close?
Thank you for the questions. First of all, it is my hope that 2021 will see many fewer deaths than 2020 for the reason that We do have vaccine, and we are prioritizing availability of that vaccine to those at highest risk of severe outcomes. However, it is critical that until we are able to offer that vaccine to everyone at that high risk, that we do continue to work together to protect them, which leads directly to the second question you asked. Part of that protection and part of preventing those deaths, preventing our healthcare system from being overwhelmed, is all of us, including business owners, making choices that support our communities. I recognize that business owners are being impacted by the restrictions and that these are causing hardships for many individuals. I also recognize that if we do not have an approach that involves all of our community members working together to prevent spread, we risk having more deaths and increasing that burden on our healthcare system. So what I would say is important is what I have always said public health does when those owners of businesses or others are not following the rules in place, which is to first approach them, understand what the reasons are for making those decisions, make sure they understand the rules that are in place and the reasons for them, and then that there will be consequences for not following those rules, because that is what our communities need right now. We need to work together to be able to prevent the spread of COVID, and for those who are impacted by the restrictions, needing to be supported by the community so that we can, again, reach out and work together to support those whose health is being impacted by our measures and those whose health is being impacted by COVID-19.
Operator, could you put through the next caller, please?
Our next question comes from Jeff Slack of 660 News. Your line is open.
Hi, Dr. Hinshaw. Thanks for taking my question. Has the province found any more cases of the South African or UK COVID-19 variant? And with kids back to school and this mutation more contagious, is there concern that we might find more in school-age children?
Currently, we have identified a total of one case that has the genetic changes first identified in South Africa, and a total of 5 cases that have the genetic changes first identified in the UK. What we know about all of those cases is that they were people who had recently traveled internationally, and that there has been some indication that there's been a very small amount of household transmission in one of those cases, but no onward transmission into the community. And at this point in time, we have no evidence that either of those 2 variants is spreading in our community. We are working with our lab to increase the number of samples that come through our lab that do get tested for these variants so that we can add additional assurance. But at the moment, again, we are not seeing any evidence through our regular genetic sequencing data that these variants have been introduced into our community at large.
Operator, could you put through the next question, please?
Our next question comes from James Keller of the Globe and Mail. Your line is open.
Hi, Dr. Hinshaw. What is happening with testing numbers? You know, we're down at 9,000 in the past day, which is less than half of what we had in mid-December. So how much is the low testing, do you think, contributing to the lower rates that we're seeing? And why do you think that fewer people are getting tested?
We know that our new case numbers certainly are dependent on the total number of tests that are done. Our lab is up to date. We have no backlog in our lab, so our lab is processing all of the samples in a timely way. We have been looking into the reasons for the low number of tests, and at the moment we don't have any specific cause for it. We do know that our testing policies have not changed. We still recommend that anyone who has any of the symptoms that could be COVID-related, and there are a long list of those, including the typical cough, shortness of breath, runny nose, fever, loss of smell or loss of taste. But moving on into some of the less common symptoms, such as abdominal pain, diarrhea, vomiting, and some of those types of symptoms, we do recommend that people go for COVID testing with any of those symptoms or close contacts of COVID or those involved in outbreaks. And none of those policies have changed. So it's at the moment difficult to say exactly what's leading to the reduction in numbers, but certainly what I would encourage all Albertans to do if they have any reason to go for testing, again, any of those symptoms or having been a close contact, that they should proceed to get tested so that we can track our numbers. I would say that our positivity rates are an important part of what helps us understand the evolution of our epidemiology, or watching the trends in how our cases are moving. And our positivity rates, the number of all of the tests that are done that test positive, has been slowly decreasing. But of course, that is only a part of the picture, and we do need to have as many people as are eligible to go for testing so we can continue to monitor.
Operator, could you put through the next caller, please?
Our next question comes from Julia Wong of Global News. Your line is open.
Hi, Dr. Hinshaw. Just to go back to contact tracing, do you have any idea when contact tracers will be able to get in touch with those not considered high priority? And can you also give us a breakdown of the community spread, so workplaces, retail, gathering, etc.?
Right now, AHS is able to reach even more than that high risk. So they are absolutely able to reach all the high risk and more on top of that. And so depending again on the trends of cases, I don't have an exact date of when we'll be able to reach all new cases within 24 hours, but we are working with Alberta Health Services to meet that goal certainly as soon as we can. At the moment, with respect to the trends that we're seeing, again, I would note that many of the activities that people would previously have participated in are not happening right now. So we don't have a current, I don't personally have a current breakdown of the specific categories within that close contact category, but the majority of the cases that we're seeing are a close contact of a known case. Often, again, we know that household spread within households is a significant risk, and so that is still a trend that we're seeing. And what I can do is we can take that away and get back to you to give you the most up-to-date breakdown of some of the more specific subcategories within that close contact.
Operator, could you put through the next question, please?
Our next question comes from Jesse Weisner of Global TV. Your line is open.
Oh, hi, Dr. Hinshaw. At the end of last year, you said the provincial lab was not testing for the variant in every sample. Has that direction changed, and is testing being done on non-travelers? And if direction has not changed, why is testing for the variant not more widespread, and wouldn't the number of cases detected so far in the province be underreported?
We have been testing up to 150 samples every week with a full genetic sequencing, and I want to distinguish here between the type of testing that we need to do routinely, not just to detect these 2 new variants of concern, but also to detect any particular mutations of concern that might arise that we don't already know about. So the purpose of testing, again, about 150 samples every week is to make sure that we're doing that full genetic analysis to be able to detect any emerging trends, including the variants, but not limited to them. In addition to that, since the variants emerged in late December, which really is only a couple of weeks ago, our lab has been working hard to develop new processes to be able to put through an additional number of tests every day that specifically look for a couple of key mutations that are common to the South African, to the variants identified in South Africa and the UK. And we will be able to do a much larger volume of our cases every day with that new test. We're working on getting the processes set up and reagents so that we are able to test a higher proportion of our cases, so that if we do end up having some transmission in our community, we'll be able to detect it as soon as possible.
Operator, could you put through the next question, please?
Our next question comes from Lauren Boothby of Edmonton Journal. Your line is open.
Hi, Dr. Hinshaw. Can you confirm that Alberta has moved to spread out the second doses of the vaccine by 42 days? If that's the case, can you quantify how effective it is? Do you have the percentage, both for if you get it between 21 and 28 days, which is what's recommended by the manufacturer, or 42 days? And if supply issues are fixed, might we return to the 21 to 28 days? Also, if there's a worry people won't get the second dose in time for it to be fully protective, shouldn't we have held on to the second dose? Is that short-sighted to just plow through more vaccines if we already know we're not going to have enough for a second batch?
Thank you for the questions. First of all, I'll say that today is a difficult day where we announced the highest number of deaths reported in a single day, well over 30. And it's exactly for that reason that we want to make sure that every Albertan who is at risk gets the vaccine as soon as possible. So the only reason for extending that interval between the 3 to 4 weeks, which is what we had previously been booking, up to the 42 days, is so that we can ensure that as many Albertans as possible get the protection of that first dose as soon as possible. What we know right now about the protection that's afforded by a single dose from the studies that have been done on Pfizer and Moderna, the estimates that of its effectiveness starting from 2 weeks after that first dose and up to when the second dose was administered is approximately 90% for that single dose. What we don't know is how long that single dose protection will last without the second dose. We know that in those studies there was a range of intervals between the first and second dose that did go up to 42 days. We don't know for sure how long the first dose protection will last, but given that some people in that study did have that 42-day interval, given that the National Advisory Committee on Immunization in Canada has indicated that this interval could be considered when vaccine supply is in very short numbers and high community transmission is taking place, and the World Health Organization has also made that statement, we felt that the responsible thing to do to prevent as many deaths as possible was to be able to provide that first dose to as many people as possible while still planning for that second dose. This is very important because it's very important that those who've received a single dose understand they do need that second dose, but being able to offer it to more people is weighed against that, extension of that interval so that we are able to broaden that protection as quickly as possible. And if we were to save half of every vaccine shipment for those who need a second dose, we would be dramatically reducing the total number of Albertans who could benefit from the early protection. None of these are easy decisions, but it's really important that as we're considering all of these options, we make sure that we're thinking about the benefits and risks at individual levels as well as the population level. And as I said yesterday, we hadn't completely finalized, and today we have finalized that decision. And every individual who's eligible for vaccine will go through an informed consent process whereby the considerations are explained to them and they can choose to accept the vaccine or not. Any appointments that were previously made will be honoured, and all residents of long-term care and designated supportive living facilities will still receive their second dose at the 3 to 4 week interval to ensure that those at the absolute highest risk get that second dose in that shorter window.
Operator, could you put through the next question, please?
Our next question comes from Matt Woodman of CTV. Your line is open.
Hi, Dr. Hinshaw. It's been more than 2 weeks since Christmas and almost 2 weeks since New Year's. So are you able to tell how have the holidays affected Alberta's COVID-19 case count?
It seems from the data that we're seeing, as well as survey results that indicated that the vast majority of Albertans followed public health measures and stayed within their own household for Christmas, that we have done well, and Albertans should be proud of that most Albertans did not contribute to further spread over the holidays. It's not quite 2 weeks since New Year's, so it is a bit early to tell fully if there has been an impact from any gatherings that may have happened at that time. But overall, it does seem that in this province, we have avoided that acceleration that some other provinces and some other places around the world have seen. What we do need to do, though, is build on that success. We still have over 800 people in hospital, and so making sure that we don't take that success for granted, but that we build on it is critical at this point.
All right, we've got time for 3 more questions. Operator, could you put through the next caller, please?
Our next question comes from Paige Parsons of BBC. Your line is open.
Hi, Dr. Hinshaw. Yesterday, Premier Kenney said Alberta might be running about 20,000 doses of vaccine short as early as next week. And how is that being accounted for? And where will the shortage be felt? Who won't be getting it, or is that just all eating into sort of the supply of second doses?
The gap between our ability to provide vaccine to people and the available supply is that shortage. So essentially, what we have been doing is building our system's capacity to be able to provide vaccine to as many people as quickly as possible. And we have the capacity to increase the number of doses that we give every day. and our supply will start to run short of our capacity, we anticipate within the next week or so. However, that supply is being taken into account, and as we make appointments available for people, we are taking into account the supply that is committed and that's anticipated to come into the province. So the way that essentially that gap is felt is that expanding into further groups of eligibility will wait until we have sufficient supply, but we will not be cancelling appointments. We are taking, again, that difference between our capacity and the supply into account as we book appointments for Albertans, and are making sure that we're giving as much vaccine as possible, as quickly as possible, but at the same time not planning on cancelling many appointments in case a vaccine shipment doesn't show up.
Operator, could you put through the next caller, please?
Our next question comes from Jennifer Lee of CBC. Your line is open.
Hi, Dr. Hinshaw. My questions are about the coronavirus variant. You mentioned that in one specific case, there was a small amount of household transmission. Can you clarify what you mean by that? Were there cases identified and how many within that household? And then when it comes to surveillance, I'm wondering, how do we know for sure that one or more of these variants is not already spreading in the community, since we're not testing every sample? And then when you do expand with that screening, what percentage of samples do you hope to be testing for the variants once you're at full capacity?
The first question with respect to household transmission, so there was a single case, again, of the travellers that I've spoken about, where within the household there were 2 household contacts, so people that first case lived with, who did end up getting COVID. While it's not been confirmed that those individuals have the variant because of the linkages, it seems likely. And again, we've done a thorough investigation of any additional contacts beyond that, and there is no evidence of any further spread. With respect to the question about testing, in terms of the percentage, it really depends on our new case numbers as to what percentage we'll test. We're really focusing on a target by the end of the month, that we would, by the end of the month, be sequencing 100 samples every day to be able to test for, again, the specific mutations that are common in the South African, the variant identified in South Africa and the variant identified in the UK. And so the percentage of our total cases will really depend on how many new cases we get. And of course, we're working to build capacity, but that's the target as we start our enhanced surveillance for these variants. As you say, we cannot guarantee that we do not have the variant, but what we can say is that through our regular sequencing of up to 150 samples every single week, we have never detected a case of the variant in the many months since we know this variant was detected in the UK. And so we are, of course, enhancing our surveillance, but we can say with certainty that the variant is not widespread at this time because we have been doing that sampling and sequencing over the last many months.
Operator, could you put through the final question, please?
Our final question comes from Carrie Tate of Globe and Mail. Your line is open.
Hi, Dr. Hinshaw. Thanks for taking my question. It's a follow-up on James Keller's question about testing. I'm wondering if you believe that the numbers might be artificially low and that there's more infections happening undetected, but we're just not seeing it because people aren't getting tested.
It has always been the case that more people are infected than get tested, so that is a constant, and you'll likely recall when we were first seeing our serology results back in the summer, and we were doing an estimate of how many cases were in the community compared to how many we were detecting through our testing. We were performing much better than many other places, but we still had an estimate of approximately 1 out of every 4, 1 out of every 5 total cases is what we were picking up through our molecular testing, which is better in many other places than the 1 in 10 ratio. So it has always been the fact that there is more transmission in the community than we sample through our PCR testing. However, the important part is that we have not changed our methodology. And so again, the way to be able to detect that is to be able to get Albertans to come forward for testing when they meet the eligibility criteria. The encouraging part about the current testing trends, while the numbers are lower, we do see that positivity rate is also starting to trend down a little bit, and the positivity rate is independent of the total number of tests that are performed. So that's why we have to watch both of those metrics closely. But again, I would urge Albertans who have any symptoms or who have any of the eligibility criteria to come forward for testing so we can monitor and make sure we are tracking as much of the spread as we can.
Thank you all for joining us. Dr. Hinshaw will provide another update tomorrow afternoon. Have a safe night.